Right. Well, good morning to everyone. My deepest regret, quite honestly, is that I can't be with you in person to present this talk in honor of Dr. Ray Hood entitled 50 Years of Trying to Improve Cancer Pain Management. I do want to say that if anyone has questions about the presentation or would like follow up, you can send me an email at UCSF and I'll be happy to respond. So before I begin my formal remarks and my talk, I would like to express my sincerest gratitude for a very, very strong foundation. When Bill Schmidt called me to tell me that I was being awarded this honor named after Dr. Ray Hood, it brought back a flood of memories of my days working in New York. For those of you that don't know me, I actually began my nursing career in New York. I have some of the fondest memories of attending meetings of the Eastern Pain Association, and I have to apologize for this blurry figure. It was the only one I could find of Dr. Hood, and it was actually on the EPA website. He wasn't someone, I guess, that took a lot of photographs. I do want to acknowledge his pioneering work and the work that he did in conjunction with Ada Rogers. Every time I give a lecture to clinicians on pain management and discuss analgesic dosing, I mention um, Dr. Hood's pioneering work in this field. And the work that he did is really continued to this day as we take care of patients experiencing pain. So before I begin my formal remarks, I want to say that I have no conflicts of interest to declare. So in terms of the objectives for this presentation, I alluded to the fact that I'm reflecting on 50 years of cancer pain management. I received my nursing degree in 1974, so I've been working in this area for 50 years. And I should add that if I hadn't become a nurse, I would have been a history teacher. So I really do like to take a historical perspective and a view on where the field has gone over 50 years. So you have to indulge me a little bit in that. I'd like to talk about some of the major achievements that have occurred in the past 50 years in terms of the management of pain in patients with cancer. And then I think most importantly for this talk, in terms of people in the audience who are thinking about clinical or preclinical work in this area, I'd like to talk a little bit about what I see are some of the areas for future research to improve the field. So, what drove my passion, I would say, for this work? It always goes back to thinking about people that I've cared for. So, I'd like to introduce this presentation with a case. I'd like to introduce you to Frank, who's a 65-year-old male who is recently retired. He's an avid gardener, and his house had a beautiful lawn, and he even put a putting green in his backyard. In right after he retired in May of 1976, his wife Helen noticed that his voice was becoming hoarse. He saw an ENT surgeon. He was diagnosed with laryngeal cancer. He received radiation therapy. He recurred. He then had a radical head and neck procedure and a laryngectomy. Frank was really adamant about learning esophageal speech, and one of his goals was to teach speech to other people who had had a laryngectomy. But in January of 1977, he had a recurrence of his cancer. He was re-radiated and was left with exceedingly severe, intractable pain and headaches. I taught his wife how to give subcutaneous morphine, and I didn't believe I was going to do this time. But this is my father. He died in intractable pain, and that led me to begin my career in trying to improve cancer pain management. And I'll come back to my father's pain problem a little bit later in this talk. So where does my journey begin? I told you I graduated from nursing school in 74. I went back to get my master's degree, and I was fortunate to attend a conference in Montreal, Canada, led by Dr. Balfour Mount. So this was back in the mid 70s. And at that conference, Dr. Mount talked about a substance called the Brompton cocktail. And this is actually the first publication I've written out of some 700. It was part of my graduate education. For those of you that are too young to even have heard about the Brompton cocktail, it was actually developed at the Brompton Hospital in London. And Brompton at the time was and still is a very famous chest surgery hospital. And it was not oncologists or hospice physicians who came up with this mixture, but actually thoracic surgeons, and they wanted to provide effective analgesics to the patients that they were doing thoracotomies on. So this product was a mixture of morphine for its analgesic effects, cocaine, which they believed was a respiratory stimulant, and to make this concoction palatable for patients, they put it in an alcohol base. They used gin and honey. Um, it provided effective pain relief. And the secret behind it, actually, that was adapted or adopted, I guess I should say, by Dame Cicely Saunders at St. Christopher's Hospice, was to do what we hadn't been doing at the time and use it in the management of cancer pain by administering it around the clock. I became really enthralled with this idea and adamant about it and brought it to the hospital that I was working at in the Bronx, Albert Einstein. And we made a concoction, actually, the pharmacy made a concoction that included morphine, cocaine, alcohol, and I think we used cherry syrup. This was not an easy thing to institute in a hospital institution, both from the perspective of getting it adopted and being having it ordered by medical oncologists. But we would have to change the formulation as the patient's tolerance to morphine developed. So the variable dose of morphine, the pharmacist would have to mix a new bottle for the patient to receive. But it worked really, really well. I looked at my own musings in this article and wanted to share some of them with you in terms of thinking about how we were considering cancer pain management in the 70s. And some of the notes that I reflected on were the fact that we viewed pain, and this was not just unique to me, it was pretty common in the literature. We would teach clinicians that cancer pain was really meaningless. It reminded the patient of his or her poor prognosis. And I made some, I thought, rather bold statements at the time, maybe not so much now, that nurses must adhere strictly to certain rules. They needed to assess pain in the setting of cancer pain management. And most of these people had terminal cancer with associated pain from bony metastases. The use of the term PRN was absurd, and we were trying to get clinicians to give medications around the clock, and then to try to convey a message to the patient that using medications around the clock could relieve their pain and provide comfort. So the 70s, the 80s, the 90s saw a trajectory in my career that once I finished my master's degree, I spent a fair amount of time as a clinical nurse specialist at the Albert Einstein College of Medicine Hospital. I worked primarily in the inpatient setting, providing cancer care as well as pain management. But I was really fortunate in the 70s to have Dr. Ronald Canner, who is um, trained and educated at Memorial Sloan Kettering by Dr. Hood and people like Kathy Foley, come to Albert Einstein, and we set up a chronic pain service. I decided to get a PhD in the mid 80s. That PhD was in neurophysiology. And then I went off to the University of California, where I still am. I did a postdoctoral fellowship with Dr. John Levine, looking at opioid pharmacology and analgesic synergy. And then in 1990, I became a faculty member in the School of Nursing at UCSF. The transition here, and what I want to emphasize in the early 1990s, for those of you that don't know about cancer care, was the time when the majority of cancer care went from the inpatient to the outpatient setting. So we had a real revolution in terms of caring for people with major headways in terms of, I think, advances in drugs that were going to improve survival. And we were starting to give chemotherapy in the outpatient setting. So up until that point, most of the research that had been done on cancer pain had been done on people in the inpatient setting, many of whom had advanced cancer. So Charlie Cleland's group at MD Anderson, our group at UCSF began to look at how big was the problem of cancer pain in the outpatient setting. And I think, like most researchers, you start with descriptive correlational work. So we recruited patients who were receiving treatment in our oncology outpatient clinics. We had this was a convenience sample. As you can see from the sample size, it was about 396 patients. When we dichotomized them into whether or not they had cancer pain or not, or were experiencing pain from their cancer, 54% of those patients told us, yes, indeed, they were experiencing cancer. And I want you to keep that number in mind, 54%. I'm giving you a short summary of this study. We looked at various pain characteristics, and the salient ones that I want to share with you are their worst pain scores on average on a 0 to 10 scale were 6.5, which we would classify as severe pain. They were in pain that was described as interfering with their daily function about 4.5 days per week. And again, in terms of hours per day in pain, um, they rated their pain on a 0 to or their number of hours per day on a 0 to 24 scale as almost 10 hours a day. Please take note of the large standard deviations for each of those characteristics. Not surprisingly, um, these patients, we used the profile of mood states to evaluate their mood. They reported higher levels compared to people without pain. Patients with pain reported higher levels of anxiety, depression, fatigue, anger, and confusion. And I just want to add here, as part of this study, we also evaluated the family caregivers of the patients with pain and those family caregivers of patients who did not have pain. If the family caregiver was taking care of someone with pain, all of the same scores, anxiety, depression, fatigue, anger, and confusion, were significantly higher in the family caregivers of the patients with pain compared to those who are caring for people without pain. So the effect spilled over onto the family caregiver. The 1990s through to the early 2000s led to what I consider some major advances in our ability to effectively manage cancer-related pain. And the first one, which some of you may, view as not such a great outcome, was we did get available on the market in 1987 MS Contin. In 1990, the Duragesic transdermal fentanyl patch came on the market. And from my perspective in caring for people at the bedside, this was revolutionary because we could give people controlled release medications that would maintain steady serum blood levels, and we didn't have to wake patients up during the night to take short-acting opioids so we could maintain blood levels. Um, the American Pain Society became involved in writing evaluation criteria to look at the quality of acute and cancer-related pain. The original paper was actually published in a book chapter because I gave the talk at the International Association for the Study of Pain on these quality assurance standards. But this is a study that was done with our group at UCSF, trying to evaluate the quality of care patients received who were in the hospital being treated for acute and cancer-related pain. In 1994, the federal government was engaged in writing practice guidelines, and there was a publication. I served on this guideline panel on how to better manage cancer-related pain. All of this work culminated, for better or for worse, and we could debate that, the Joint Commission issuing pain standards for hospitals. And at that point, pain became the fifth vital sign. From my perspective, this work in the setting of individuals who are experiencing pain from cancer um, reduced a lot of barriers to patients taking medications to relieve significant amounts of cancer pain. And it allowed us to provide education to patients, to family members, and to clinicians on effective management of cancer related pain. However, we all know what happened as a result of the Joint Commission initiatives, the standards that were promulgated by the Centers for Disease Control, as well as various pain organizations. Um, there was inappropriate use of particularly long-acting analgesics like or controlled release analgesics like temescantin, which led us into um, somewhat of the state we're in now in terms of what we have labeled an opioid epidemic in this country. But has that epidemic had consequences in terms of the management of cancer related pain? From my perspective, what the conversation around the opioid epidemic led to was a recognition that we need to manage chronic pain differently. And there is now an emphasis not so much on the pain score, but how is the pain management plan, and by that I mean both pharmacologic and non-pharmacologic interventions, influencing patients' function. We've implemented a system of universal precautions around the use of opioids and an assessment of patients for risk of misuse. And my read of the studies that have been done in this space in relationship to cancer-related pain is that the risk of misuse in people who have pain related to their cancer is no different than the general population in the United States, which is about 20%. I do want to point out that the Drug Enforcement Organization in this country actually controls the amount of opioids that are produced. And their restricted production of opioids for a period of time led to opioid analgesics not being available in hospitals, and that required the cancellation of, cancer surgeries. So that situation has abated, but it was a serious consequence of some of the effects related to the opioid epidemic. My own read in terms of the associated fears of addiction in the cancer patient and survivor community is we're back to where we started 50 years ago. People are very, very afraid of the addictive effects of opioids, and it may influence effective cancer pain management. I think being in this field for so long, a number of things, but particularly the opioid epidemic has created a chilling effect on the development of new analgesics. And I think that's had serious consequences in advancing how we can effectively manage pain in people with cancer. Few pharmaceutical companies are willing to take up the charge to develop um, new analgesics to treat serious pain problems. So we're now, at 2024, where are we in terms of the prevalence and the common problems associated with cancer, and the common pain problems associated with cancer? So the there's been repeated meta-analyses from de Groff's group in I think they're in the Netherlands, trying to do systematic reviews of pain prevalence. And the two most recent publications from this group, one is in patients getting active treatment, and the other one is in cancer survivors. And I'd like you to take a look at the summary of their data. In terms of cancer patients, this is a follow-up review that they did prior to studies being published in 2024. They added, 2014. They added 12 additional studies. I think one of the challenges with the epidemiology of understanding the epidemiology of cancer pain is most of the studies have focused on people with breast cancer or lung cancer. Um, in the outpatient setting, based on this group's work, the pooled prevalence of cancer-related pain is 40%, or the pooled prevalence of cancer patients experiencing pain is 40%. The data in cancer survivors suggests that 50% of survivors are living with significant pain. And I want to point out, because I'm going to come back to this point, for both the patients receiving cancer treatment work and the survivor work, the group noted that there's a large amount of variability across studies in the prevalence rates. And they call for a need for more studies with better assessment and management of cancer pain. So our group has been engaged in this work, trying to look at some of the questions related to prevalence, some of the questions related to interindividual variability in patients with cancers, pain experiences, as well as risk factors for worse pain profiles, both from a phenotypic perspective as well as a molecular perspective. And I just give you a sample of the papers that we've published in this area, but I want to emphasize, I think, some salient findings. So much of the work has come from a study that was supported by the National Cancer Institute that was actually focused on symptom clusters. And we call this study the Symptom Clusters Study. It's a study of patients receiving chemotherapy. We enrolled people with 4 types of cancer that are listed on the slide. And for this work, we recruited a cohort of over 1,300 patients. They were assessed 6 times over 2 cycles of chemotherapy, and I'll show you the schema for the assessments on I think it's the next slide. And then we assess pain using the brief pain inventory, as well as multiple other symptoms. I want to show you briefly some salient findings from the first cross-sectional analysis that was done at enrollment, where we assessed patients prior to their second or third dose of chemotherapy. So for this analysis, we wrote it up when we recruited 926 patients. And in this study, certainly a convenient sample, which has its limitations, but almost 73% of patients reported pain. And what I want to emphasize in this slide is the fact that people with cancer are living longer. This was a mixed sample. About 50% of the patients were getting initial treatment for their cancer, 50% were getting treatment for recurrence of disease. We broke down the patient's self-report of their pain based on whether they reported only non-cancer pain causes to their pain, only cancer pain causes to their pain, or both. And you're going to see in my recommendations for future research that this is an area, if you look at the people that had pain, almost 50% of them had pain attributable to both their cancer and some other chronic painful condition. This is an area we have to work on and drill down on more. If we compare the patients with both types of pain to patients who did not have any pain, the patients with both types of pain were more likely to be female, less likely to be married or partnered, more likely to live alone, less likely to be employed. They had a lower annual income. They had a lower poor functional status, and we use the Karnofsky status scale to measure functional status, and they had a higher comorbidity burden. Areas that we would most likely today suggest are significant social determinants of health. So I want to show you some data from the longitudinal analyses from this study. And this was quite an ambitious project in that we enrolled patients and began our assessments. Assessment 1, which was the enrollment assessment, was done by the patients um, um, prior to their second or third cycle of chemotherapy. The second assessment of all of the symptoms we looked at was done 1 week after chemotherapy, and the third assessment was done approximately 2 weeks after chemotherapy administration, depending on the length of their cycle. So 14 days, 21 days, 28 days. We adjusted the timing of the assessments to meet this general framework. And then we repeated it again, the same idea for 3 additional assessments. So we have a total of 6 measurement points for the patients after they were enrolled and we obtained informed consent. And this gave us the opportunity to look at changes in pain over time and to begin to understand some interindividual variability in pain in these patients and risk factors associated with that. So um, we've become really, really interested in trying to understand inter-individual variability in pain and other symptoms in patients receiving cancer treatment. And most of you are aware for any symptom study, and if we call out pain in this case, because it's the topic of this lecture, previous longitudinal studies basically report means and standard deviations. And I've always been of the belief that the information in the standard deviations is much more meaningful than just the mean pain score, let's say in this case. And so I guess it was up until about maybe 15 years ago, we really didn't have a statistical method to begin to understand interindividual variability in pain or other symptoms in any population that you wanted to study. And a lot of this work in terms of applying it to symptoms came out of a group in the Netherlands that was understanding psychiatric problems. And people in the past had tried using cluster analysis. Our group even did that. Cluster analysis itself has a fair number of limitations. The new analytic technique that I would recommend if you do longitudinal work that you should consider evaluating is what's called latent variable modeling. And it can take a slide like this, which is called a spaghetti plot, random plot of, let's say, symptom trajectories or pain trajectories, and it can group patients who have similar profiles. So you begin to discover groups of patients who are similar to each other from individuals who are unique. What makes latent variable modeling useful is that it has established criteria for determining the optimal number of classes. And I'll show you an example of that on the next slide. Once you get the class assignment, the profile, you can then use that categorical variable to examine or evaluate for phenotypic and molecular risk factors. And that's some of the work that we've been doing, and I'll present one of the groups of studies from that work in the next couple of slides. So this is an example of a table that shows our work looking at latent profile solutions and fit indices for worst pain across the 6 assessments in the patients that were receiving chemotherapy. And basically what you base the class solution on is the Bayesian information criteria and the VLMR. So entropy usually sits around 0.7 to 0.8. That's a good number. When you start to do these analyses, you ask the software to give you a 1-class solution, a 2-class solution, a 3-class solution. In the case of pain, we asked for a 4-class solution. And what you begin to see in terms of using the Bayesian information criteria is the number gets smaller and smaller. And then in many instances, although it didn't do it in this case, the next class solutions BIC gets larger. Sometimes with big sample sizes, you don't see that, but we've begun to use a formulation where we judge the optimal class solution based on the BIC in conjunction with the VLMR. And when the BIC is low and the VLMR goes from being significant to non-significant, we choose the class solution before the non-significant VLMR. So to do this analysis, We removed the patients that did not have any pain across the 6 assessments. And those are the people here at the bottom. And then we ran the latent profile analysis on the worst pain intensity scores and came up with, as the optimal solution, a 3-class solution. Just for your edification, the classes come out numbered 1, 2, 3, not necessarily in any order. So as a clinician, you need to look at the pain scores and label the classes based on some clinically relevant metric. So we had people that pretty much across the 6 assessments, this is about 2 months, had mild pain scores. We had a group of patients who had moderate pain scores and a group of patients who had persistently high pain scores. And you can see here that if you look at risk factors, 55% of the patients had moderate to severe pain. So then you get to ask the question, who are these patients? What are the characteristics that make them unique and help to explain some of this inter-individual variability? Because I often talk to clinicians and say, if you have 100 patients in the clinic, and you want to do some sorting, what characteristics might lead you to believe that you've got patients that are in these 2 top tiers? So here's what we found. And I'm just showing you the publication gives you all of the post hoc contrasts. But if we were to compare the patient characteristics of people who had no pain to those that were grouped into the profile of severe pain, the demographic characteristics were fewer years of education, being female, being single, being unemployed, having a lower annual income. The clinical characteristics were, again, poorer functional status, higher comorbidity burden. The only diagnostic group that's had significance, quite honestly, in any of the symptoms that we studied is the GI cancer group. They tend to have a lower symptom burden, and I'm not quite sure why that is. That's something I think that needs to be needs to be studied and understood. And then we used a measure called the self-administered comorbidity questionnaire, where the patients, there's a list of 13 common medical conditions, and the patients tick off whether they have those conditions. In the setting of severe pain, a higher percentage of patients reported anemia, clinically diagnosed depression, osteoarthritis, and back pain. And then we evaluated a large number of psychosocial characteristics. Our group was really interested in stress, and we measured global stress using the perceived stress scale, disease-specific stress using the impact of event scale revised, higher cumulative life stress, higher level of PTSD, and lower levels of resilience. So things we can target. We've done some preliminary work, again, with an extreme phenotype approach, looking to see if we could distinguish using gene expression data, pathways that were significantly perturbed between the patients who didn't report any pain compared to the patients with severe pain. And you can see here the list of KEGG pathways that were identified in the areas of neuroinflammation, signal transduction, and neurotransmitter pathways. And each of these pathways does have a relationship to pain. So if you're interested in that, you can read the complete publication that was on one of the earlier slides. We did a study in cancer survivors, and we haven't gotten around to publish the pain data from that study, although we do have some other publications. But I did the analysis in brief to be able to share this with you. Cross-sectional data, convenience sample, recruited from a variety of sources. We have a little over 1,100 patients in this study. You can see they've lived a long time with their cancer. About little less than half are receiving treatment. The occurrence rate for pain in this sample, convenience sample, was 62.1% of the patients reported pain. And again, you can see the breakdown of the types of pain these patients are experiencing. And I can tell you that the medical oncologist is not evaluating the patient's non-cancer related causes of their pain. The pain scores are really as high as the ones for the patients in the inpatient setting or the outpatient setting who are receiving active treatment. And we asked patients on a scale of 0 to 10, with 0 being no relief to 100% or 10 being complete relief, what their relief was, average at best. Again, we see some central themes here around um, risk factors. Younger patients more likely to report pain, women more likely to report pain, unemployed individuals more likely to report pain, higher BMI, higher comorbidity burden. We see redundancy, different sample in the self-reported diagnoses that are contributing to, I think, the pain burden, depression, osteoarthritis, and back pain. And this pain is having a significant effect on patients' activity levels and function in the survivorship period. We also measured stress in these patients, and again, a similar pattern to what we saw in the patients receiving chemotherapy. Higher levels of disease-specific stress, higher levels of post-traumatic stress disorder. Because this was COVID, the COVID period, we were interested in trying to understand social isolation, loneliness, and there's been quite a lot of interest now in understanding the financial burden of cancer on patients, which is labeled financial toxicity. And you can see from this slide, clinically meaningful levels of loneliness in these patients, higher levels of financial toxicity, and higher levels of social isolation. And I can say for the most part, this sample was not socially isolated. They were lonely, but they were not socially isolated. But the pain patients had a higher level of social isolation. So where does this need to go in terms of future research? Um, my own belief is that we need good epidemiological studies. We need data on different types of cancer and their association with pain, different types of treatment, more work needed on people getting active treatment versus survivors. We have only touched the tip of the iceberg in trying to understand non-cancer, the non-cancer pain causes of pain in a patient with cancer, and trying to sort that and its impact if it occurs alone or in conjunction with cancer-related pain. A hot topic in cancer research right now is multimorbidity. The majority of cancer patients have more than one chronic condition, and that's growing as people receive more cancer treatment that results in chronic conditions, as well as just the effects of aging. So we don't have a good handle on multimorbidity and pain. We need more work on risk factors, underlying mechanisms. Does having non-cancer pain in conjunction with cancer pain influence the mechanisms underlying the pain? I don't know. I think we need to revisit the 70s when I started and try to understand where the barriers are to effective cancer pain management and how they influence adherence with the analgesic regimen, and then what effective methods are out there to improve management of cancer pain. So I know I only have about 15 minutes left. I want to talk about the two, what I consider the two unresolved pain problems for cancer patients in the 21st century. And one of those is driven by my case study, because at the time we knew nothing about cancer-related neuropathic pain in the setting of cancer. And so I think, we were treating my dad with morphine, but he really needed medication to treat neuropathic pain. So the two conundrums that I want to talk about are post-surgical pain and chemotherapy-induced peripheral neuropathy. And if we look at chronic post-surgical pain, I'd recommend that you read this review. It is noted in this review that it is the most frequent complication of surgery. The median incidence at 6 to 12 months is 20 to 30%, so this is not an insignificant problem. The incidence of pain, at least from the preliminary data, it suggests that it differs by type of surgery. And you can see the range there reported across studies, which again suggests a large amount of inter-individual variability. The patient populations that are at risk are ones that there's big surgery: breast cancer, thoracotomy, head and neck, and nephrectomy. Although I should state that even in our work with lumpectomy, patients did experience chronic post-surgical pain. So we've published a lot in this area, both from the phenotypic perspective as well as from some molecular characterization. And we took the tactic of trying to understand breast pain being distinct from arm pain. And we've gotten those papers published, and so I think we've made the case that those two things are indeed distinct. But I don't think anybody else has followed up on trying to understand these two distinct pain problems in people getting breast cancer surgery. So maybe somebody will be inspired to do that. We again, in this work, used latent variable modeling. We, in this case, used growth mixture modeling to do the analyses over 6 months. We looked at trajectories for breast pain versus arm or shoulder pain. And you can see we took out the patients that didn't have any pain from both analyses, each site. And you can see that we got a very different profile for breast pain than we did for arm pain in terms of the evaluation. So again, suggesting these might be different pain problems. But the prevalence rate is quite high. 70, little under 70% of the patients had some type of breast pain for 6 months, and the trajectory was pretty constant. And we have almost 60% of the patients had arm pain that was that persisted for 6 months of the study. The characteristics that were similar in terms of being risk factors for breast pain and arm and shoulder pain are listed on this slide. I want to point out that in this study, we asked whether the women were experiencing pain in their breast prior to surgery, and it was a significant predictor of postoperative breast pain. I didn't think they were going to experience arm or shoulder pain prior to surgery, so we didn't ask the question. So that's why it's not on this slide. But what played a really significant role in persistent arm and shoulder pain was the number of breast biopsies the patients had prior to surgery, whether or not they had received neoadjuvant therapy prior to surgery, or excuse me, neoadjuvant chemo prior to surgery, and whether they had a higher stage of disease, which meant more extensive surgery in the axilla. So what do I see as the future directions? Majority of the research in this topic has been done in breast cancer surgery. So again, recruiting and evaluating patients with other types of surgery. I think particularly in the space of head and neck cancer, where we're doing surgery with other modalities, this is a particularly significant problem. We need more work that characterizes risk and protective factors in these patients, including stress. We didn't measure stress in these patients. More work on molecular characteristics. Are there common or distinct mechanisms for chronic post-surgical pain syndromes? And then more work needed on what types of preemptive interventions will reduce this problem. And I know there is work in that space, but I think we need more. If you haven't heard about this study, it's called the A2CPS study. It stands for Acute to Chronic Pain Signature Study. This, and I put the website there. I invite you to check it out. It's a study that's being funded, a large-scale study that's being funded by the Common Fund out of the director of the NIH's office. It is recruiting patients, probably the largest sample of patients with who are going to have knee replacement surgery, as well as patients who are going to have undergone thoracotomy. And patients are being followed for a year. Because this study is being funded by the Common Fund, in the spring of 2025, they're going to release the first cross-sectional data on these patients. I'm a consultant on this project. I'm not collecting data, but I can tell you this is the most exquisite characterization from a phenotypic perspective of patient characteristics that can contribute to acute and chronic pain after surgery. It is going to have functional MRI imaging data, as well as biomarkers, genetics, proteomics, metabolomics, lipidomics. Um, and the data will be released in stages, and it will be open to the public with all the manuals and training videos for how to use the data. So I invite you to take a look at this because it's going to be a wealth of information for those of you that want to write grants on this topic. The NIH will entertain new grants on this project. Briefly, I want to talk about chemotherapy-induced peripheral neuropathy, largely from the perspective of cancer survivors. People are living longer with their cancers, as you all know, and currently we have about 14 million survivors in the United States. It's expected that that number will double in the next decade. And with that, patients are experiencing increased survival, but the deleterious effects of cancer treatment. And one of those is chemotherapy-induced peripheral neuropathy. Again, prevalence rates are really, really wide in this area, 10 to 60% of patients. And you can see here some of the characteristics that have been evaluated or types of symptoms that have been associated with CIPN. This is not an insignificant problem. People with this condition have balance problems, they have falls, and we've recruited patients with this problem, and I can tell you it has significant negative consequences on people's quality of life. We have had patients that have been Michelin star chefs who can no longer cook because they can't hold the knives. In one of our studies, we had a concert pianist, professional pianist, who could no longer play. We've had farmers who can't drive tractors because they can't feel their feet, and it's dangerous to do that. We've had surgeons that can no longer operate because they have significant neuropathy. So this is one of the unresolved pain problems of our time. Again, we publish things on this. You can look us up, and all my collaborators are listed there, for whom I am very grateful. So I want to give you a nutshell of some of the salient findings. This was a cross-sectional study, convenience sample. We purposely oversampled people with neuropathy. And in this study, we were the first actually to describe what the prevalence rates were for the neuropathy in terms of did they only occur in the hands, they only occur in the feet, or both. And what you know clinically is most people have problems with both the upper extremities and the lower extremities. The risk factors between people who didn't have neuropathy and those who did were older age, lower annual income, higher BMI, higher comorbidity burden. Surprisingly to us, and the reason I asked this question was I was at a conference and a nurse said to me, I noticed that my patients who were born prematurely were more likely to get neuropathy than patients who weren't. We had very few patients who were born prematurely in the study, but in the regression analyses we did, if you were born prematurely, you were 5 times more likely to be in the CIPN group. So that's a finding I'd like somebody to confirm. Receipt of higher cumulative doses of chemotherapy, which has been known to be associated with increased risk for neuropathy, was found in our patients with it, and our survivors actually with it, and they had a poorer functional status. So a couple of other things I want to point out if people are going to go into this space. We very casually in this study, and have since followed up with it, asked patients about hearing loss and ringing in their ears. And to our surprise, a little less than half of the patients had another neurotoxic or another neurotoxicity. And you can see the distribution here. What's interesting about this data is most of the work that's been done in neurotoxicity, or in hearing loss and tinnitus, has been done in children and in patients who have survived testicular cancer. There was virtually no literature that hearing loss and tinnitus occurred as a result of neurotoxic chemotherapy in patients with breast, GI, and lung cancers. And so We got a lot of attention from that in the press because we did a follow-up study and saw the same type of numbers. And what I want to leave you with, if you're clinicians in this audience, is that the type of hearing loss that patients have from chemotherapy-induced, or sorry, from neurotoxic chemotherapy drugs is amenable to a hearing aid. We did objective measures in this study in terms of Sem-Weinstein monofilaments, and not unexpected findings in the people who had neuropathy compared to those who didn't. Higher pain scores, greater loss of protective sensation, worse mobility measures, more severe balance problems, higher mood disturbance, and poorer quality of life. We did look at, because we always got questions about, did the drug matter? All right. And so we, in this study, had most of the patients that either received a platinum compound, a taxane compound alone, or a platinum and a taxane compound. And you can see the distribution of the patients in terms of the sample size and the respective percentages of patients who got which drug. It took a lot to get this paper published because we found no differences in pain intensity. None of the objective measures of sensation, light touch, pain, vibration differed. No differences in common symptoms, and no differences in quality of life outcomes. So the drug doesn't matter in this case. It's whether you've got the neuropathy or not. We did a very small pilot on trying to tease out some molecular mechanisms because we weren't funded to do gene expression work in this study. But in a very small pilot, I think there were 30 patients in the study, we came up with some very interesting pathways that need to be replicated in terms of whether or not they appear perturbed in other samples of patients with and without chemotherapy-induced peripheral neuropathy. But I invite you to read the paper if you're interested in that. So what's the future directions? Number one, I think we need a clear definition and diagnostic criteria for CIPN. And we need to consider, because we've done this work, that if you talk to patients and you invite patients to participate in a study of CIPN, 50% of them do not report pain. The most common symptom is numbness, and we really need to sort that out. I can't measure numbness in a rat, to the best of my knowledge, but that's the symptom that's most troublesome to patient. It's not pain. We need to know risk factors. There is no data on the time course for development and resolution of CIPN, either as an acute condition, a time-limited condition, or a chronic condition, and what's associated, what risk factors are associated with each of those. My own belief is to advance this field, and I think we can do this easily with patients receiving chemotherapy. We need to understand multiple neurotoxicities in the same patient and see potentially if there are overlapping mechanisms. And we did neuropathy, we did hearing loss, we did tinnitus. I think more work needs to be done in taste and smell as well as cognition. I don't want to beat a dead horse about molecular mechanisms, but that's the key to finding new targeted therapies. And then the impact of single or multiple neurotoxicities on patients' ability to function and their quality of life. I know I'm at the end of my time, and I just want to briefly suggest that not only can you model a single symptom, but we need to move forward and model co-occurring symptoms in patients with cancer. And I offer this data to you in terms of, this has been repeated not only by our group, but by other groups, that patients on active treatment experience an average of 13 symptoms. Survivors experience an average of 10. And there is, with every symptom that we've investigated, a large amount of inter-individual variability in patients' symptom experiences. If you're interested in what symptoms we always measure in patients, we do depression, we do anxiety, we do sleep disturbance. We're interested in diurnal variability in fatigue, and we found some interesting findings related to that, as well as decrements in energy. Fatigue and energy are not the same thing, and we've written about that, and I think I've actually demonstrated convincing evidence that they're not, and then cognitive impairment. We have done work doing joint modeling. of symptoms. And if you're interested, I picked one of the ones we published on pain, where we were interested in pain and decrements in cognitive function. And when you do that kind of modeling, these are the figures you get. So we have a no pain group with pain on the left y-axis, cognitive function on the right y-axis, higher score on this measure of cognitive function, which is the attentional function index, means better cognitive function. So we have a group, with no pain, and this scale would define these people as having moderate levels of cognitive function. We have people with moderate pain and really high levels of function, but here's the group that I worry about: severe pain and low levels of cognitive function, and another group, moderate pain and moderate cognitive function. Who are these people? And let's just look at the risk factors. The people in this high pain, low cognitive function class, younger, again, fewer years of education, higher comorbidity burden. We're seeing a pattern here. Lower functional status, more likely to live alone, lower annual income. And I have to tell you that this sample of patients was um, from Northern California, which is a fairly affluent group. So to get a risk factor of lower annual income, it wasn't that low. Um, Again, these people reported higher rates of depression, osteoarthritis, back pain, more stress, and we've become interested, and I would suggest that others might want to look at this. We've become very interested in adverse childhood experiences and their contribution to a higher symptom burden. And we've demonstrated in this paper that people with high pain and poor cognitive function reported higher rates of some very substantial adverse childhood experiences. Future directions for this in terms of multiple co-occurring symptoms, we need to think about and try to understand what's driving the multiple co-occurring symptoms. In other words, what's the sentinel symptom? And I've done some work with people who have told me that you could do network analysis sort of in silico with data and remove symptoms and see if it changes the network. If anybody's interested in that, knows how to do network analysis, I'd love to work with them on that because we've got the data. We need to understand over time what symptom is driving, which symptom is driving which symptom, and that can be done through statistical procedures like parallel growth process modeling. We need more work on social determinants of health in trying to build the risk factor portfolio for multiple co-occurring symptoms. I sit and wonder all the time whether or not many of these common symptoms have common underlying mechanisms, and that's an area for future research. And then bringing this to the clinic in terms of clinical trials, do we try to do single symptom interventions and then measure effects on co-occurring symptoms, or do we do multiple symptom management interventions? And I don't know the answer to that question. I'll leave that to you to think about and design experiments to answer. I didn't make a slide with all of my collaborators. I feel I acknowledge them on all the publication slides. I am extremely grateful to all of them, to all of the learners and mentees that have worked with me over the past 50 years, the funding agencies who have supported our work, and probably most importantly, the patients and family members who have contributed so much of their time and their information to help us answer these questions. Again, I want to thank you for being the recipient of this award, and I hope you have a wonderful, highly fruitful conference. And as I said, if anybody wants to reach out to me via email, I'll be more than happy to meet with them. Thank you for your attention.